Welcome to this explainer. Today, we're diving into one of the most intense, straight-up life-threatening endocrine emergencies you might ever face in the ICU or the ER. We're going to explore exactly why your clinical intuition absolutely has to outpace the laboratory. Whether you're a medical student just learning to identify these crises or a junior clinician refining your triage skills, this step-by-step review is designed to arm you with exactly what you need to know.
Okay, let's jump right into this. Think about it. What actually happens when waiting for lab results quite literally kills your patient? Because with thyroid storm, we're looking at a devastating double-digit mortality rate, specifically 10 to 30% in the ICU. Because the stakes are that high, this has to be an urgent, purely clinical diagnosis. You simply cannot wait around for confirmatory blood tests, like a TSH or free T4, to slowly make their way back from the lab before you act.
Here is our roadmap for today. We're going to cover the clinical emergency itself, triggers and masked symptoms, scoring the storm, a rapid assessment case study, the stabilization protocol, and finally, the crucial drug sequence.
All right, Section 1, the clinical emergency. Let's define what we're dealing with.
A thyroid storm isn't just your standard overactive thyroid, right? It's a rare, extreme clinical expression of thyrotoxicosis. What really sets it apart is the severe systemic decompensation. We're talking massive cardiovascular, gastrointestinal, and central nervous system manifestations. The patient's hypermetabolic state spirals completely out of control, and any delay, even a small one, can lead to vascular collapse, shock, and ultimately a fatal outcome.
Moving on to Section 2. Triggers and masked symptoms.
Now, you might think an explosive endocrine emergency like this would be super obvious to spot, but these crises rarely happen in a vacuum. They are almost always triggered by some secondary acute event. So what are the usual culprits? Well, a lot of times it's a systemic infection, like pneumonia, or simply a patient abruptly stopping their antithyroid drugs. But it can also be sparked by surgery, physical trauma, an acute iodine load from a medication like amiodarone, or even childbirth. Honestly, identifying that trigger is just as vital as treating the storm itself.
And there's a really fascinating rule of contrast to keep in mind here. Younger patients, they usually present with classic hyperandrogenic signs. We're talking severe agitation, high fever, extreme tachycardia. But older adults frequently present with what we call apathetic or masked thyrotoxicosis. They don't look hyperactive at all. Instead, they exhibit severe lethargy, which falsely mimics secondary illnesses like heart failure, delirium, or sepsis. It's totally deceptive.
Section 3. Scoring the thyroid storm. Let's talk about the Birchworth-Foskey scale.
Because presentations can be so heavily masked, we need objective frameworks to triage patients instantly. The Birchworth-Foskey point scale is your absolute gold standard here. Instead of relying on a TSH level that might take hours to come back, this system uses specific observable clinical signs. You're going to look at their temperature, their heart rate, check for atrial fibrillation, signs of congestive heart failure, GI dysfunction, and their central nervous system status to calculate a definitive risk value.
And here is the crucial takeaway. The numerical threshold is 45. Hitting a score of 45 points or more on this scale is highly suggestive of a thyroid storm. This number is your giant, flashing green light. It dictates that aggressive, multi-pronged therapy absolutely must begin immediately. Again, do not wait for those lab results to confirm what your clinical exam is already screaming at you.
Let's see this in action. Section 4. Rapid assessment case study.
Okay, picture this. Meet patient G. She's a 78-year-old female brought into your fast-paced ER. She presents with severe lethargy, she's in new-onset atrial fibrillation, and her temp is 101.5 degrees Fahrenheit. Now, at first glance, she looks a whole lot like a classic case of sepsis without a source, or maybe heart failure in an elderly patient. This is exactly that apathetic, masked presentation we just talked about.
But let's apply the scoring tool to her, rapidly. For her moderate fever of 101.5, she gets 15 points. For her lethargic mental state, that's 20 points. And for the atrial fibrillation, she gets another 10 points. Do the math, and that's a total of 45 points. Boom, she just hit the critical threshold. You've diagnosed a thyroid storm purely on clinical grounds, and it is time to act right now.
Section 5, the multi-pronged stabilization protocol.
So how do we treat this? Well, immediate treatment isn't just a single magic bullet. You must initiate a multi-pronged pharmacological blockade. You've got to systematically shut down the synthesis of new hormone, the release of stored hormone, and the systemic effects of the hormone that's already circulating around in the blood.
To do that, we rely on 4 main pillars of treatment. First, you block the dangerous hyperadrenergic tone using beta blockers, like high-dose propranolol.
Second, block new hormone synthesis using thionamides. PTU is usually favored here because it actually stops peripheral conversion too. Third, block hormone release using iodide solutions, like Lugols. And fourth, block the peripheral conversion of T4 to the much more active T3 using glucocorticoids, like hydrocortisone.
Alongside all of this, you absolutely need aggressive supportive care. You'll be using IV fluids for resuscitation, often with some dextrose for calories, and you have to treat their fever. But listen up. Here is a massive clinical pearl for you. Cool them down with blankets and acetaminophen. Never, ever use aspirin. Seriously. Aspirin actually inhibits the protein binding of thyroid hormones, which acutely spikes the free active thyroid hormone levels in the blood. You'd literally be making the storm dramatically worse.
Section 6, the crucial drug sequence. This is where things get really intense.
The exact sequence in which you administer these drugs is, no joke, a matter of life and death. It's a fatal pitfall for a lot of junior clinicians. First, you start with your beta blockers and steroids to stabilize the patient. Next, you must administer the thionamide, like PTU, to completely block new synthesis. Then, and this is critical, you must set a timer and wait a strict minimum of 1 hour before you give the iodine solution.
So why the wait? It's because of a phenomenon related to the Wolff-Chaikoff effect. If you give the iodine too early, before the PTU has fully locked down the hormone factory, you are just handing the hyperactive thyroid gland massive amounts of raw substrate. The gland is just going to use that iodine to build even more hormone. You'd basically be pouring gasoline onto the fire and accelerating the storm.
In a ticking clock scenario like this, your structured clinical evaluation is your greatest and, sometimes, your only tool. As we've seen today, thyroid storm is deceptive, fast, and incredibly deadly. So, trust the point systems, respect that strict drug sequencing, and act decisively. I'm going to leave you with this final thought to chew on. When the storm hits your unit and your patient is decompensating right before your eyes, will you wait for the labs or will you act?